Hello, welcome to Satellite Symposium sponsored by SANOFI Korea. This session title is Novel Pathway for Intensive Lipid Lowering Therapy. We have two excellent lecturers and then two famous panelists. So I'd like to introduce two panelists, Dr. Upendra Kaur from India and Dr. Wei Chim Tan from Singapore. Yeah, okay. So we will start with the first lecture. The first lecturer is Dr. Chung-gi Kim from Ewha Women University, Seoul Hospital. His lecture title is Landscape of Lipid Management Following an ACS Event. Dr. Kim, please.
Thank you, Chairperson. I'm Chung-gi Kim from Ewha Women's University. Today I'll discuss about recent progression and changes in lipid management in ACS patients. I will discuss the following steps. CVD mortality is not decreasing but increasing, actually due to higher burden of CV risk factors, most recently age and other comorbidities in US and other developed countries. Since more than 30 years ago, there has been reported that higher cholesterol level is associated with higher mortality of coronary heart disease. There was a linear correlation between cholesterol level and the mortality. Furthermore, landmark RX study showed LDL cholesterol level has a significant impact on CVD risk. Now we accept cholesterol level is the most important risk factor to contribute incidence and prognosis of CVD. And such high LDL cholesterol level have more profound impact on the risk among the patient with high risk, severe risk profiles. Exposure to LDL cholesterol may progress atherosclerotic change in coronary arteries. The concept shows the close association between cumulative exposure of LDL cholesterol and total plaque burden, which may relate it to the incidence of clinical vascular event. If we lower the LDL cholesterol level, the risk of MI and clinical event will be delayed according to the cumulative LDL cholesterol exposure concept. Earlier initiation or more intensive LDL cholesterol lowering therapy may have more benefit with minimizing exposure of LDL cholesterol. However, there is still unmet need to reduce severe risk. In the statin trials, there was significant reduction of severe risk with statins or more intensive statin, but there was still remained the risk about 60 or 70%. Furthermore, there was still substantial number of patients experiencing major CV event during statin treatment. And it was not feasible to drive significant reduction of CV or all-cause mortality with LDL cholesterol reduction itself in many trials. In the real-world practice, one of significant problems for the ACS management is that it is not easy to achieve target LDL cholesterol level with only statins, even good adherence. Achievement of LDL cholesterol below 70 milligrams per deciliter was only 19% in post-ACS patients in the trial. It's obvious that optimal LDL cholesterol management would not be easy, only with statin in clinical practice. According to DICE's 2 trials in China and Korea, the target achievement of LDL cholesterol is only 63% in China and 64% in Korea in patients with LDL lowering treatment. Actually, high intensity dose of statins, atorvastatin 40 or 80 milligram or rosuvastatin 20 or 40 milligram showed more than 50% reduction in LDL cholesterol, and such effect may be more intense in Korean and other Asian populations. Meta-analysis showed that superiority of more intensive statins for CV reduction will not be related to the baseline cholesterol level. So the statin benefit will be consistent irrespective of LDL cholesterol level. Furthermore, both statin and non-statin agents reducing LDL cholesterol level seem to have a consistent benefit even in patients with cholesterol level below 70 milligram per deciliter. And delayed initiation of statin showed higher risk of CV event in recent investigation as well. So we should consider early initiation of statin will be important for many patients. As I explained, long-term exposure or LDL cholesterol level may be more beneficial. Population with genetically low LDL cholesterol level has had more profound effect of severe risk rather than those population lately grow the LDL cholesterol level with statins. Now let's focus on the PCSK9 mutation related to LDL receptor. There are two types of mutations, gain of function and loss of function. The former decrease the clearance of LDL receptor and number of LDL receptor, and it results in increase of LDL cholesterol level. Otherwise, the later form of loss of function increase LDL cholesterol number in the population. So in such patients, the mutation will be protect from atherosclerosis and coronary heart disease. So such loss of function mutation show the association of lower LDL cholesterol level in population study. In such patients, PCSK9 inhibitor loss of function mutation delivered about 90% reduction of coronary heart disease in the study. Thanks to the many investigations will rapidly drive the development of PCSK9 inhibitor. So now PCSK9 inhibitor is available to use in clinical practice since 2012. Alirocumab facilitated LDL receptor recycle on the surface of hepatocyte, resulting in reducing plasma LDL cholesterol level. There is synergistic effect with alirocumab and statin because of inhibition of cholesterol synthesis biosynthesis and increasing cholesterol clearance by LDL receptor. Now, I'd like to say that this is cholesterol error coming again because of robust evidences of non-statin agent trials, improved Fourier trial, Odyssey outcome trial, that alirocumab showed significant benefit in terms of composite ischemic endpoints. So recent European guideline in 2019 focused on lowering LDL cholesterol goal. So it also should tell us that the use of PCSK9 inhibitor should be considered in selected patients, and early use of the agents also mentioned on the guideline. So target LDL cholesterol goal is becoming 55 milligram per deciliter in very high risk patients who having ASCVD, documented ASCVD, and advanced CKD and diabetes with target organ damage. They mentioned that define the very high risk, including very diverse risk profiles. So we should focus on such risk factors to management patients to lower LDL cholesterol. Therefore, combination with ezetimibe and PCSK9 inhibitor was emphasized to achieve target LDL cholesterol goal. However, it is still questioned when and how long we should use such more intensive non-statin agents in very high-risk patients. In Da Vinci study, it is sure that many patients require combination to ezetimibe and PCSK9 inhibitor to achieve target LDL cholesterol goal. We can see that even with ezetimibe or PCSK9 inhibitor, we can achieve only about 50% to their target LDL cholesterol goal. But the use of such non-statin agent was about only 10%. So we should emphasize that the use of non-statin agent in clinical practice, and it is obvious that there is still underuse of such agents. As I mentioned, the ICES-2 trial demonstrated that there is underachievement in terms of target goal LDL cholesterol in global goal attainment is only less than 40%. In Korea, that goal attainment about 60%, but long-term attainment is also very low in Korea. So it is a very big problem in clinical practice, I think. In the guideline, the PCSK9 will be the one option for the patient to start early in the event. However, we should follow the indication of PCSK9 inhibitor about 4 or 6 weeks later if he take maximally tolerated statin and ezetimibe. So I'd like to review the guideline and proposed algorithm for the very high-risk patients. According to the guideline algorithm, we need 8 or 12 weeks to achieve LDL cholesterol goal if the patient is resistant to the oral agent. From the onset of ACS, we might start maximally tolerated statin for 4 or 6 weeks. We need this period to check the patient will reach the LDL cholesterol goal. If the cholesterol was not reached, then we will start add on ezetimibe, and we should spend another 4 or 6 weeks for the choose PCSK9 inhibitor for the patients. So I'd like to suggest that in such high-risk patients, we should start maximally tolerated statin in addition to ezetimibe initially. And also, I'd like to use PCSK9 inhibitor during the admission if we have high-risk features, and then we can select, or we can recheck LDL cholesterol level after 8 weeks, and we can consider to restart PCSK9 inhibitor. If he was not injected with PCSK9 inhibitor, we can continue the algorithm to recheck LDL cholesterol after 4 or 6 weeks, and we will consider to start PCSK9 inhibitor. This is potential change of LDL cholesterol level in resistant patients. If we follow the stepwise guideline-directed algorithm to titrate the LDL cholesterol lowering agent, we will start statin first, and if he was resistant to the statin, we will add on ezetimibe, but the cholesterol level was still higher in very vulnerable early phase, and then we can choose the PCSK9 inhibitor about 2 or 3 months later, and then we can achieve the LDL cholesterol goal. I propose that intensified algorithm with early PCSK9 injection. We can starting ezetimibe and PCSK9 inhibitor very early phase, because the phase will be very vulnerable in terms of the plaque characteristics. So we can start the agent to rapidly lower the cholesterol level, and then the cholesterol level will be rapidly decreased and restored consistently. So we can check the LDL cholesterol level about 8 weeks later, and then we can decide whether we use PCSK9 inhibitor or not. This is summary. Achievement target LDL cholesterol level is suboptimal, especially in those at very high risk of severe events. Many evidence support early initiation, sufficient intensity, and long-term use of LDL cholesterol lowering therapy for better outcomes. Early use of PCSK9 inhibitor will be considered in selected high-risk patients after ACS. Thank you for your attention.
Thank you for a nice lecture, Chung-Gi Kim. And I'm going to introduce the next topic. Today, the next topic is a PCSK9 inhibitor, effect of alirocumab on cardiovascular events and mortality after acute coronary syndrome. Hanbi Park is going to giving a lecture from Gangneung Asan Hospital. Please give a lecture, Hanbi Park.
Hello, I'm Hanbi Park from Gangneung Asan Hospital in South Korea. It's an honor for me to have the opportunity to present TCTAP 2022. Today, my topic is the effect of alirocumab on cardiovascular events and mortality after acute coronary syndrome. Alirocumab was studied in the family hypercholesterolemia patient group and high cardiovascular risk patient groups through the ODYSSEY clinical trial program. So the current indication for alirocumab, first indication is primary hypercholesterolemia and mixed dyslipidemia, and second indication is established atherosclerotic cardiovascular disease. Today, I talk about two clinical trials. First is the ODYSSEY outcome trial. It's a pivotal trial of alirocumab, and the ODYSSEY KT trial is conducted in Korean and Taiwan patients. First, I talk about ODYSSEY outcome trial. A study on the effect of alirocumab on cardiovascular outcome in patients with acute coronary syndrome. The ODYSSEY outcome trial was conducted in 57 countries around the world. Total 18,924 patients were enrolled in this study. Therefore, patients of various nations were enrolled, and also 94 Korean patients were enrolled in this ODYSSEY outcome trial. So, 100% of the study population had a previous myocardial infarction or unstable angina, and about 90% of study population were receiving high-intensity statins. High-intensity statins means atorvastatin 40 or 80 mg per day, or rosuvastatin 20 or 40 mg per day. In baseline characteristic, median age was 58 years old, and female was 25% of study population. And about 65% of study population had hypertension, and 29% of study population had diabetes. Clinical manifestation at index admission, non-ST segment elevation MI was 48%, and ST segment elevation MI was 34%, 34%, and unstable angina was 17%. The basket was performed in 72% of study population. The randomization was performed in about 3 months after index coronary syndrome event. In medication, about 90% of study population were taking high dose of atorvastatin or rosuvastatin. The patients were enrolled in this study between 1 month and 1 year after index coronary syndrome event. After randomization, alirocumab group for the first 2 months, the study patient took 75 mg of alirocumab every 2 weeks. After 2 months, the study patient took 75 mg or 150 mg of alirocumab. To achieve the target LDL cholesterol level was 25 to 50 mg deficit with maximal tolerated dose of statins. The study follow-up period was 2 to 5 years. The study primary endpoint were major cardiovascular events, which was composed of a coronary disease death and non-fatal MI and ischemic stroke or unstable angina requiring hospitalization. Secondary endpoint is coronary heart disease event, which was composed of coronary disease death and non-fatal MI and unstable angina requiring hospitalization or ischemia-driven coronary revascularization. And major coronary disease event was coronary death or non-fatal MI. And cardiovascular event was composed of cardiovascular death and non-fatal coronary disease event and non-fatal ischemic stroke. And coronary vascular death and all-cause mortality was evaluated in this study. And In addition, the safe data of adverse event and laboratory data was also evaluated in this study. As mentioned earlier, the target adverse level in this study was 25 to 50 milligram per deciliter with the maximally tolerated dose of statin. If two consecutive measurements of adverse level were below 50 milligram per deciliter on the 75 milligram dose of irinotecan, was blindly switched to placebo for the remaining duration of the trial. This is a slide, is the study design summary. The study population was the descent occupational syndrome with other high-risk features such as diabetes and prior coronary disease and recurrent events and prior stroke or peripheral artery disease. Study follow-up period was 2 to 5 years, and irinotecan and placebo was compared to lower adverse level with the maximal tolerated statin dose. And the primary endpoint was coronary heart disease endpoint. That's the endpoint. This slide is the result. Irinotecan group showed a 55% mean adverse level reduction at 4 years compared to placebo group, and it showed a tendency to sustain mean LDL cholesterol level reduction after treatment. And the primary efficacy endpoint measure adverse cardiac event, which was a composite of coronary disease death and non-fatal MI and ischemic stroke or unstable engine requiring hospitalization. The irinotecan group showed a 15% relative risk reduction at 4 years compared to the placebo group. In subgroup analysis, in particular in patients with baseline LDL level above 100 mg per deciliter, the irinotecan group showed a 24% of relative risk reduction and 6% of absolute risk reduction in MACE at 4 years compared to the placebo group. And in the follow-up study patients for the more than 3 years, the irinotecan group showed a lower all-cause mortality compared to the placebo group. This was a novel finding that had not been confirmed in PREA trial. PREA trial is the pivotal study of irinotecan. And compared with the overall study population, the benefit of irinotecan over all-cause mortality was more pronounced in the patient group followed up for more than 3 years. And irinotecan showed that 15% relative risk reduction in MACE and all-cause mortality, and the risk reduction in the irinotecan group was more pronounced in patients with baseline LDL cholesterol level above 100 mg per deciliter. Currently, we use the two PCSK9 inhibitors available in clinical practice. The one is irinotecan, and the another is everolimus. The Odyssey outcome trial is the first published PCSK9 inhibitor study showed the risk reduction in all-cause mortality in the PCSK9 inhibitor treatment arm. And all cardiovascular events, non-fatal MI and ischemic stroke and unstable angina and coronary disease event and major coronary heart disease event were consistently lower in the irinotecan group than the placebo group. The incidence of adverse event was similar in the irinotecan group and the placebo group with the exception of the injection site reaction. Irinotecan showed a favorable safety profile, no increased risk of nuanced diabetes, and no increased risk of hemorrhage stroke, and no increased risk of neurocognitive disorder. This slide is the summary for Odyssey outcome trial. The primary endpoint and irinotecan showed a 15% relative risk reduction of MACE, and a greater absolute benefit in MACE was shown in particular with baseline LDL cholesterol level above 100 mg per deciliter. The irinotecan group showed a 55% reduction in LDL cholesterol level at 4 years, and the irinotecan group also showed a risk reduction in all-cause mortality. And irinotecan showed a favorable safety profile. Last, I talk about Odyssey KT trial, which is evaluating the efficacy and safety of irinotecan in South Korea and Thailand population. The study population was a high cardiovascular risk patient who were on maximally tolerated statin dose. Study follow-up period was 2 years. The difference point compared with Odyssey outcome trial was the titration of study drug. If the LDL cholesterol level was 70 mg per deciliter or higher at 8 weeks, the dose can be increased only once at week 12. This slide is the result. irinotecan group showed a 67% 3% of mean adequacy level reduction at 2 years compared with to the placebo group, and it showed a tendency to sustain mean adequacy level reduction after treatment. At week 24, 86% of patients in the elucumib group reached the adequacy level below 70 mg per deciliter. In subgroup analysis, in particular in Korean patients, the elucumib group showed 77% of mean adequacy level reduction, and week 24, 92% of patients in elucumib group reached the adequacy level below 70 mg per deciliter. In safety data, elucumib was generally well tolerated with no significant safety signal. This is my last slide. In very high risk patients with prior acute coronary syndrome and stroke, current 2019 ES guideline recommend lowering adequacy level to less than 55 mg per deciliter. In this very high risk patient group, if the target adequacy level cannot be achieved in the maximally tolerated dose of statins, the additional PCSK9 inhibitor is recommended in current guidelines. However, currently in Korea, elucumib can be used only when the target adequacy level is 70 mg per deciliter or more, despite the use of maximally tolerated statin for adequacy level under the reimbursement. So, however, in clinical practice, I recommend actively considering the PCSK9 inhibitor elucumib for lowering adequacy level in your patient very high cardiovascular patient. Thank you.
Thank you, Dr. Bach, for excellent lecture. So it's time to discuss. Previously, I forgot to introduce myself and then my co-chairs. I'm Chang Nam from Gaming University, Korea. And then my co-chair is Dr. Han-Chol Lee from Busan. So is there any question or comment about the two lectures?
Maybe I can start. I think firstly, there's no question that lowering LDL cholesterol level in patients with acute coronary syndrome is a requirement. It's almost like a standard care of, that we carry out now. And based on the data that is available, it would also appear that there is no late clinical effect or or any price to pay when we lower the LDL aggressively. So even if you start out with the regimen that Dr. Kim has suggested, that you give statins, acetamides, and PCSK9, there appears to be no major downside to it, even as low as LDL of 0.5 millimole or 20 milligram per deciliter, at least based on the current data. And what is also more important to me is that if you start LDL lowering early during hospitalization, the adherence rates after discharge is also better. So if you start medicine early, it is likely that patients will continue. So these are all very important points. The only thing that I feel at this point in time that has not been answered is that how soon should we be starting this statin therapy? I recall that in Miracle trial before, we used to give high intensity statin versus placebo in patients with ACS 1 to 4 days after the onset of event. And so, but then subsequent trial like Proof It, they give it 10 days after ACS. So now whether if we start early, even before PCI for patients with ACS or during the admission, will it bring about an earlier benefit? Will it bring about a greater benefit? That will be something that we still don't know very well. So perhaps maybe Dr. Kim or can give us its idea, or Dr. Park. How soon should we be starting, and should we be giving it even during primary PCI, for example, in patients with STEMI?
Okay. So how about Dr. Kim? You suggest that kind of a method in your presentation. So I'd like to some comment about Dr. Tang's comment. So I totally agree with the concept. So earlier, stronger is better for especially acute coronary syndrome patient, especially for during the before the PCI or after just the PCI. But One issue is we don't have enough data about the extremely earlier lipid-lowering therapy will make a better outcome or not. Still, we don't have no evidence about the clinical benefit. So previously, high-intensity statin was earlier better. We see the 60 weeks, 4 weeks later, there are some difference after high-intensity statin therapy. But we don't have such kind of result, clinical outcome about the usage of a PCSK9 inhibitor. So theoretically, it's ideal, but still we have to get some more clinical data about that result. So, Dr. Kim, do you do such a lipid lowering treatment strategy for your patient in HS patient?
Yes, I try to use that high intensity study in my very early phase. So I try to give patients that oral pill if the patient is available to take the medication as early as possible before or after primary PCI. And then also I try to start PCSK9 inhibitor very early phase of if he has a high risk profile, as I mentioned, that polyvascular disease or very diffuse and vulnerable future of plaque, and then diabetes, CKD, and it will be one of the indications for early admission or PCSK9 inhibitor. So I think that it's the early and intensive cholesterol lowering therapy will be contribute to stabilize the plaque, because the very vulnerable plaque has very large pool or lipid core pool. And then IBUS study showed that the very intensive LDL lowering therapy might affect on the plaque regression, which is mostly contributed by reduction of lipid pool. So, and that many PCSK9 inhibitor studies, sub studies show that the patient with recent event have more profound effect with PCSK9 inhibitor. Within 1 year, the patient with experienced MI within a year have more effect with PCSK9 inhibitors. So, the many doctors said that there is no robust evidence, clinical outcomes, related clinical outcomes, but I think that the single shot of PCSK9 is not very expensive in Korea. It's about more than about $120, and then ezetimibe would be not expensive, I think, because that they have very serious event. So such expense would not be very profound for many patients.
Okay. Well, this is Dr. Kaul. I think one of the very important developments which have happened during our lifetime of doing PCIs for acute coronary syndrome is that when we do a PCI, we take care of 20 millimeters or maybe 30 millimeters depending on the length of the lesion. But there are miles and miles of coronary arteries, which many studies by intravascular imaging has shown they're full of vulnerable plaques. And besides, antiplatelet therapy, which has a very important role in acute coronary syndrome, passivating these plaques by high-intensity statins is very, very important. And I think there is enough data to suggest that patients who get an acute coronary syndrome, their second event, if it has to come, and it comes often, it happens early. It happens, within few months. And this is the time when we have to act really very hard and to minimize, to keep the LDL cholesterol at the lowest level is the best possible thing. I keep on telling my students, don't worry about taking a serum lipid sample, get a report in the evening or tomorrow morning, and then, titrate the doses. Go with the highest dose, add ezetimibe, they're all available, and, giving them very high dose is always very useful. Coming to the situation when a very high-risk patient comes, high risk means a young patient with a family history, diabetes, and also a second event which is happening within the next, within few months. This is the patient population where I would seriously consider giving them PCSK9 inhibitor at that stage, and start them on evolocumab. I know that in our country it becomes difficult because of its cost, and it's not in many insurances it is not reimbursable. But then we always recommend it and start it, and see that the LDL cholesterol levels in these patients come down to 30s and 40s. And I think along with the other good measures like antiplatelet agents for a long period of time, these have really changed the outlook and changed the prognosis favorably in these particular patients. And there are so many new developments coming in this field that, inclisiran is coming. I think it has already been approved by the US FDA and European Union, where you have to give injection once in 6 months. Then there are certain agents like bempedoic acid, which are already available, which you can combine with statins, ezetimibe, and further reduction when short of using the injectable PCSK9s and other thing. So I think this is a very evolving area, and a lot of work is being done, and we are very clear that lower the better, especially in acute coronary syndromes and in very high risk acute coronary syndromes. Lowering it to the minimum levels is there. There are many things which are not clear by the data which we've been discussing, but then I think it makes sense and it's very logical. The agents have got very low side effects, very little toxicity. Go to any low levels, you don't get any hemorrhages, you don't get any dementias, you don't get any major issues. So my take is that go to the lowest level, and in very high risk patients, start everything together.
Basically, I agree with your advices, but I think we need some more data about early use of PCSK9 inhibitor for acute coronary syndromes, because as you know, is lipid lowering effect is tremendously effective of PCSK9 inhibitor, tremendously effective PCSK9 inhibitor, but we don't know the PCSK9 whether PCSK9 inhibitor has highly anti-inflammatory effect or not, like statin. So we need some more data about PCSK9 inhibitor before acute coronary syndrome PCI. So it is a definite high lipid lowering effect is very definite, but high inflammatory effect is slightly ambiguous with this drug. So we need some more data, and then we need a well-designed randomized study.
Yeah.
This is my opinion.
Yeah.
What are the situations in which you would, in spite of having, lack of data in some of the subsets, but what are the situations of acute coronary syndrome, high-risk acute coronary syndrome, where you would still recommend using PCSK9 in the beginning?
Yeah, right. Because we know that in the ACS patient, we treat the high-intensity statin and also ezetimibe, then add the PCSK9 inhibitor. So we know that even though we use the PCSK9 inhibitor, but the high-sensitive CRP level was not much changed. So it means, as Dr. Lee mentioned, that the anti-inflammatory effect is not so strong, just a lipid lowering. But the high-intensity statin have an anti-inflammatory effect also. So basically, we first line is a high-intensity statin. But as Dr. Kaur mentioned, that especially in the very high-risk patient, especially ACS and then other polyvascular disease with diabetes, in such case, just the high-intensity statin sometimes is not enough to control the enough lipid lowering. So in those cases, definitely need the PCSK9 inhibitor. And I also have one comment about the racial difference about the Asian people and then Caucasian people. Some Korean patients, the baseline cholesterol level is not so high in the even though patients have ACS. In those cases, some doctors are hesitate to use the strong lipid-lowering therapy. So about the Dr. Bach, so in the baseline cholesterol level is lesser than 100 milligram per deciliter in those patients. What is your strategy to treat?
In current guideline, in patients with atherosclerosis cardiovascular disease, 70 milligram deciliter and 50% reduction. So I used one below 100 LDL cholesterol level. I used atorvastatin 10 or 20 milligram per deciliter or rosuvastatin 5 or 10 milligram. I usually use for him.
So it's some issue in those regimen because you already mentioned that we need to reduction at least 50% LDL cholesterol reduction from the baseline. So the user moderate intensity is starting like atorvastatin 20 milligram or rosuvastatin 10 milligram. We cannot reduce 50% from the baseline. So we should start with very high intensity statin because rather than 70 milligram per deciliter with a moderate intensity statin is possible, but 50% reduction is impossible. So definitely we need at least start with a very high intensity statin, rosuvastatin 20 milligram at least, and then atorvastatin 40 milligram plus sometimes ezetimibe. Then I think even though in those patients, sometimes we need additional treatment like PCSK9 inhibitor. But usually baseline lesser than 100 milligram per deciliter, we don't need PCSK9 inhibitor. But we have to remember, we have to reduction more than 50% and lesser than 70 or 55 milligram per deciliter according to the patient risk group. So Dr. Tong, yeah.
Yeah, I just have two comments related to that. First of all, in somebody coming with acute coronary syndromes, the LDL cholesterol actually drops after the onset of ACS. So when you assess a patient's LDL lipid profile on admissions after ACS, it may not be the true lipid profile of the patients before the onset of events. So that's one thing. And second thing here is that even if the patient's LDL level is not very high, I think giving high intensity statins so far have not been shown to have any downside or price to pay, because we know that there's nowadays no more threshold for low LDL. It is as low as possible. So like I say, even up to 0.5 millimole or 20 milligram is still shown to be safe. So I feel that in patients with ACS, I think we should still continue to pursue the strategy of a high intensity statin regardless of the LDL level. Coming back again to Chairman Dr. Lee's comment on the data needed for the use of PCSK9 in patients with ACS. Well, actually, I know of at least three different trials evaluating a PCSK9 in patients with ACS. One of them uses alirocumab, which is the VCU ALIROS-RT trial. And then there's another two trials which evaluated evolocumab in EVAX and EVOPAX. Unfortunately, all these three trials look at the LDL lowering as the primary endpoint. It is not the clinical outcome. So you're right, we don't have an outcome study, but at least we know from these three trials that the lowering of LDL acutely seems to be safe and seems to be effective as well as we expect of a PCSK9.
Thank you for great comments. So I'd like to ask to Dr. Kim. So we have two different doses of PCSK9 inhibitor in alirocumab. So would you please comment about some lower dose of PCSK9 inhibitor? Is it useful in your practice?
Sorry, the agent was not available in our hospital, so I'm limited to explain about the lower dose of alirocumab this time. But I think that the alirocumab is the only single dose, so I can titrate the dose for the patient even if we have very low LDL cholesterol level. But in that time, I really need to use that lower dose of the PCSK9 inhibitors in terms that the patient is very low LDL cholesterol level, the low dose will be effectively used for that patient.
I want to ask the Dr. Park Han-bit also, what do you think about the dose problem in Korean and ASEAN? Especially, I think small dose, low dose is enough for the ASEAN and the Korean, according to the Odyssey KT data. What do you think about the dose problem, Dr. Park?
In Odyssey KT trial, the irocumab 75 ml low dose irocumab is about 80% of the population. So I think that we usually use the I have no experience for irocumab. I usually use everolimus. Everolimus dose by 2 weeks. Every 2 weeks we injection, but I think that every 4 weeks enough for in Korean patient, because Korean patients very effective in PCSK9 inhibitor. So I usually use every 4 weeks PCSK9 inhibitor in my practice. So in low dose everolimus 75 mg is very useful in Korean patient.
I'd like to short comment about Dr. Ari's question. So I involved the Odyssey KT trial. So in that study, we didn't actually, according to Odyssey trial, there was a dose titration, but the Odyssey KT trial, we didn't have a dose titration. So we recommend use of upper dose. So from the baseline, nearly, especially in Korean patient, nearly 70% of LDL cholesterol was a reduction available, and then it was maintained until the end of the study. So it was very effective. That's why I mentioned that the lower dose of PCSK9 inhibitor. So in Asian people, some who are very low baseline low LDL cholesterol level. Sometimes we just, even though we use the high intensity statin, but very close to 70 milligram per deciliter, in those cases, insurance covered with low dose of alirocumab. And then we can reduction very close to nearly 30 to 40 milligram per deciliter. But as Dr. Tan mentioned that lower is better. So now concept is moving lower and lower. So previously, when we start Odyssey KT study, we worry about lesser than 25 milligram per deciliter because the Odyssey trial uses that kind of up titration. But nowadays, there is no lower limit. So in current situation, we can use both doses of alirocumab.
Would you like to comment, any of the persons who has some experience or literature based, what about the intravascular imaging studies of the TICFA and other things happening with the PCSK9? Because obviously it's going to be difficult to differentiate the effect of statins, which are already on in the highest dose, maybe with ezetimibe. And when you add this, does it have any known effect, or does it reduce it, or does it increase the thickness of vulnerable plaques? Because that's going to be very important for the follow-up of these patients, because they have many other subsidiary plaques.
Right. Dr. Kaur's mention is very important for the prediction of future event. So according to the previous imaging study, after usage of PCSK9 inhibitor, there is a regression of percent arterial volume according to achieved LDL cholesterol level. So I believe the plaque reduction is very correlated with cholesterol reduction. And it was very similar as a previous high intensity statin study. And about the cap thickness and the bulbar plaque morphology, we don't have enough published data, but I know that the use in Japan group use the alilocumab and then they do the serial follow-up of intravascular imaging, but I didn't receive still see the result of original paper, so we can expect the result. But we believe the previous high intensity statin study showed the cap thickness was increased and the variability is decreased after high intensity statin. And I also do the similar study use of high intensity atorvastatin Forte study. Previously last year, Eurofacial right-breaking trial was presented in those study. In those study also showed the 50% reduction and lesser than 70 milligram per deciliter. If we achieve that kind of LDL cholesterol target goal, the plaque was regressed and the lumen was increased. So FFR pro was increased. So adequate optimal lipid lowering therapy will reduce plaque volume and then stabilize plaque and then increase of a coronary flow. So we can prevent the future event, I believe.
Thank you.
Okay, even though we have some time, they recommend the level for this session. So thank you for joining all the lecturer and panelists. We have a great lectures and then great discussion about the alilocumab use in ACS patient. In the future, we have more data about the stronger and longer and earlier use of alilocumab. Thank you for joining.
Thank you.
Bye.
Thank you.
Thank you.